Good evening, everyone. Welcome to yet another webinar of CIMS JIC 2020. We have with us today Dr. Anish Chandarana and Dr. Tejas V. Patel, who will be talking on guidelines, changes in the management of hypertension, and current status of EWARD for dissecting aneurysm of thoracic aorta. So, thank you for joining us, Dr. Chandarana and Dr. Patel. We will now go to the videos, please.
Good morning. Thank you, Kirbai. No conflict of interest. Now, if you look to the guidelines, 1977, JNC1 was released, and then subsequently European guidelines were also released, and then every 5 to 7 years they are updated. From 2013, SCAH took over from JNC about guidelines. Now, if you look to the traditional view of guidelines, they are set of suggestions or recommendations by experts who have collective wisdom, and they would let other physicians know that how to treat a given disease. So the role of physician was like in those era role of a field umpire. Whatever decision a physician used to take in consultation with the patient and family was accepted, and the guidelines were sort of bystanders. They were not edicts or laws. From that state, we have moved to an era where guidelines are focusing too much on evidences, and we believe that only prospectively defined primary endpoints from randomized controlled blinded clinical trials should be considered in creating guidelines. So only a small fraction of information available on this earth is used to create guidelines, and judgments, experience, recommendations, suggestions, consensus, all is put aside. So again, today, a role of clinician or a physician is like a field umpire, but then he is closely watched by the DRS or the decision review system. So guidelines may be saying something else, and you as a clinician may be doing something else. So this is how the philosophy of guideline, from just a good emotional suggestions to a very strong legal-based advices, it has changed. So what are the areas in which guidelines have changed? Number one, the way hypertension is defined. Previously, it was 140 by 90 by all guidelines, but now American College says that once you cross 130/80, you are hypertensive. Threshold. So when you should start treating a patient with blood pressure and what should be the goal? This is always a big confusions and differences amongst all. And then what is the impact of age? Now again, SCCHA has lowered the bar. They say that once a patient has crossed 130/80, and if patient is high risk, you have to start treating the patient, and age doesn't matter. Even if a person is 85, 90, you have to think of 130/80. And they also say that there is no role of comorbidities. You just keep treating patients to 130/80, while other guidelines do believe that after a certain age, you have to be a little liberal. Say, for example, European Society, they say that once a gentleman elderly is 65, 70, 75, you can be satisfied at little higher goals. A very important point, and where almost all guidelines agree, is you have to integrate cardiovascular risk in defining goals and threshold. What do I want to say? Exactly, it is taking the shape the way lipids guideline took. Previously, we used to believe that if your LDL cholesterol is 110, there is no need to treat. But then subsequently, people came to know that if you have got already heart attack and 110 is bad and you are a high risk candidate. So even if seemingly normal cholesterol should be brought down in people with high cardiovascular risk, now world is shaping towards even seemingly normal blood pressure should be brought down in people who are high risk. At the moment, it's going on that direction, has not reached the goal. Existence of J-curve. Obviously, J-curve is always there. If you reduce a blood pressure to zero, you cannot live. But what is the level at which J-curve starts? From where the U-shape starts, or from where after certain reduction of blood pressure, CV risk increases? At the moment, again, American College of Cardiology has not mentioned any words, but European Society does say that 120/70 is something below which you shouldn't try. That's where problems start. What should be the first line of agent? Everybody's clear. ACD, ACE inhibitor, ARB, or calcium channel blockers, or thiazide type of diuretics. These should be the first line. Beta blocker has been pushed aside for complicated cases. Almost all guidelines are saying now combination of treatment, and that too if preferentially single pill, is good to improve compliance and give results. Chasing systolic versus diastolic blood pressure. You know, I mean, there are so many senior doctors sitting here. When they started their career, they always believed diastolic BP to chase is more important. But we know that both are important, but more is systolic BP, because most of the people are more than 55, 60 years of age and they have got isolated systolic hypertension. The way office BP is measured, it has changed from a lying down patient with an old sphygmomanometer to a seated patient in unattended room where there is nobody, neither nurse, no doctor. Automated BP instrument takes the measurement 3, 4, 5 times and gets an average. So this is how all the trials are using BP measurement. And we all know that importance of out-of-office BP measurement has gone tremendously high. There had to be hardly a patient in your career or in your life now onwards who doesn't have either proper home blood pressure monitoring or ambulatory BP monitoring. If you are treating a patient without these two, mostly you are doing something wrong. So that's where every patient whom you see has got blood pressure for the first time. You have to have either a home BP management or ambulatory blood pressure monitoring. So taking few points from there, if you look to SCCH guidelines, they say that once you are in 130 to 139 or 80 to 89, you are already stage 1 hypertension. Why do they say so? 140/90 was a point in blood pressure. Hypertension was a term coined by we doctors, that when blood pressure crosses this level, the risk of heart attack and stroke and death goes up. That's why 140/90 was defined. But now with our knowledge that the risk of cardiovascular disease starts from 115/75, there is no role of maintaining the definition of 140/90, because even if in this zone, when your patient has got BP of 132/84, his risk of cardiovascular disease, death, MI, and stroke is already 2.5 times more than the normal. So if you say that the risk is 2.5 times here, but still it is not hypertension, it's not good. So according to me, I personally agree to this point. Definition is 130/80. But yes, European society still, and most of the other societies still stick to 140/90. But to me, it's very important to understand the risk. What about the treatment goals and targets? Again, SCCHS says that less than 130/80 in everybody, irrespective of age, irrespective of whether you are having CKD, diabetes, CVD, or nothing else, 130/80 is the goal. And what they say is there are multiple trials and meta-analysis to suggest that if you reduce BP to less than 130/80, there are tremendous benefits. And on the top of that, it does help. No confusion, clear message, too simple. Though there are people who criticizes that one size cannot fit all. But let me tell you, you read this chart of European Society of Cardiology Guidelines. I will ask all of you at 5 p.m. today, who would remember this and who would remember this? I'm very sure 99% of doctors cannot remember such complex, long charts. And that's why these are the arguments of SEC. They said that let's make it simple, less than 130/80 for everybody. European Society, still conservative, says that let's go to less than 140/90. And then once patient has tolerated 140/90 well, try to go to 130 or less, but never go less than 120. So again, if you have to summarize this, a very big chart, it's very simple. Go to less than 140/90, check about the tolerance, side effects. If patient is tolerating not well, patient has some issues, you stop there. If patient is happy with the treatment, there are no issues, try to go as low as less than 130/80, but don't go to less than 120. So if you look to even European Society of Guidelines, ultimately they boil down here. Once they say that 140/90, then go to less than 130, but then they have made a lower line that don't go to less than 120. And again, if you look to the comorbidities, for most of them, the guideline is saying. Sprint trial has heavily affected the guidelines, and that is through SCCHA guidelines. Now see, one point I would like to mention here, it was a positive trial saying that if you change the systolic BP to almost less than 120 versus 140, there is more benefit. Now that's where even the J-curve has been challenged. See, in this trial, people who achieved systolic BP of 121, they had diastolic BP of 68. And those who were liberally treated, like the way we treat, had systolic BP of 136/76. So in spite of having diastolic BP less than 70, this group, which had systolic BP sufficiently suppressed or reduced, had a significant benefit in MACE, not only benefit in MACE, but also benefit in all cause of death. So that's why SCCHA says that don't worry too much about diastolic blood pressure, even if it goes to 65, provided you are treating the systolic blood pressure and provided your patient is tolerating the treatment. To end the confusion, Accomplish trial did help us. This was not a trial for BP targets, but this is extrapolation. What happened in this trial? Who achieved more than 140 versus those who achieved between 130 to 140 versus those who achieved between 120 to 130 and those who achieved less than 120. They were compared for 3-point MACE, and what was found? Those who achieved between 120 to 130 had the best benefit. And if you look to the cardiovascular death, once those who achieved less than 120 to 130, if further reduction was done in this trial, cardiovascular death started increasing. So what they said is 120 is something which looks reasonably okay. So coming to sort of conclusive slide and carry home message, guidelines have been changing in the last many years because newer data has come and there are more evidences. You have to have ABPM or home blood pressure monitoring. threshold and goals of BP treatment have lowered, and that's very important. In today's world, for most of the patients, the goal is less than 130. Try to chase that. Obviously, you need to be careful about side effects. ACD are the preferred first-line agents for uncomplicated hypertension, while beta blocker is reserved when patient has heart failure, post-MI, LV dysfunction, or young people with high sympathetic activity and young ladies who are still desirous to become pregnant. Combination of drugs, particularly as a single pill combination, has moved ahead and almost all guidelines are supporting. Though at the moment we are not very clear, but less than 120/70 seems to be a little unsafe zone. So in your patient, you may stop here. And CV risk-based treatment of BP lowering medicine is the future, that if your CV risk is high, reduce your blood pressure. Even if it is 110, take a pill, reduce it to 100. If there are no adverse effects, you will have benefit in heart attack and stroke. Thank you very much. Good morning, ladies and gentlemen. Before I start what I want to speak, let me make little basic clear. I believe most of you have seen at least one case of aortic aneurysm. Aortic aneurysm are basically of two types. One is fusiform dilatation of a part of aorta, and second is dissection into the media of aorta. So both of them are called as aneurysm. It can be located either in ascending aorta or arch. It can be there in the thoracic aorta, or it can be there in abdominal aortic aorta. So for this aneurysm, not every aneurysm needs some kind of surgical or interventional treatment, but there are certain indications for which you need to intervene with these aneurysms. And one of them is endovascular repair, or what is called as endograft placement. So I'm going to discuss endovascular repair or endograft placement in aortic aneurysm. So let me understand how many of you have ever dealt with aortic aneurysm. So any one of you in your clinical practice has seen at least one patient of either fusiform or dissecting aneurysm. Your time starts now. Can we have audience response system on? Yes. So wonderful. Most of you have seen one case. And let me tell you, all those who have seen at least one case and those who have not seen a single case, we all have missed at least few cases. Because aortic aneurysm, rupture of aortic aneurysm, dissecting aneurysm, these people just come to us with sometimes non-specific, sometimes specific complaints. Before we can diagnose, they die or they disappear. So that's why it's very, very important to have high index of suspicion. Look at the story of my patient, 62-year gentleman, hypertension smoker. On the previous evening, left-sided acute severe chest pain radiating to shoulder and back, took painkillers, went to GP, improved partially. Next day morning, pain recurred, same severity, and had a syncope. Then he was brought to our ER in conscious position. He had past history of left nephrectomy, tachycardia, hypertension, saturation, borderline. All four limbs pulse were normal and equal. CVS, nothing specific. ECG, minimum mild STT changes. Echo, normal, no RWMA. Troponin, twice upper normal limit. Urea creatinine on higher side. That is very important. Hemoglobin 12, count normal. DAPT, statin, IV metoprolol, IV NTG, all started by a good ER physician. Patient was willed into pre-cathol area. I was doing one angioplasty at that time when patient came. So ER physician talked to me, and then patient was willed in with a view that let's do coronary angiography as early as possible. I saw the patient in whole area. I was not happy with the diagnosis of acute coronary syndrome. I believed there is something which may be missing. And I also knew that whatever I want to do, whether I want to do straightway coronary angio, aortogram, I had a limitation of dye because creatinine in a single kidney patient head was 1.7. So like we have been discussing, you need to understand what is the pre-test probability of any situation. So this is called as acute aortic syndrome. And you have to define what is the clinical probability in a given patient to have acute aortic syndrome. So those patients who have got certain risks like Marfan syndrome, family history of aortic disease, patient with already pre-existing aortic valve disease or aortic aneurysm, or any patient who has history of manipulation of aorta because of some cardiac surgery, they all are at high risk of rupture or dissecting aneurysm. And when pain is typical, chest or back or abdominal pain, abrupt onset, severe intensity, ripping or tearing, this is a pain which is quite specific of dissection or aneurysm rupture. And then if that patient has got pulse deficit or blood pressure difference between the arms or focal neurological deficit, these are all the patients where you have to suspect something wrong with the aorta. So I had a dye limitation. So I asked my radiologist to do first plain CT thorax because I didn't want to spare 25, 30, 40 ml dye for coronary angio if patient had no coronary syndrome. I didn't want to go straight away for aortogram because again, if patient has no aneurysm or no dissection, I wanted to use the dye for the coronary. So I asked my radiologist to do just one plain CT and he replied me, doctor, there is left hemothorax, and there is a large aneurysm in the aorta. The diameter is more than 65 millimeter. And I was very sure this was a ruptured but sealed aneurysm, and that patient survived. When he had syncope, he was almost dead, but luckily in the hemothorax, the blood clot came in between, and his aneurysm got spontaneously sealed. So this is the autogram. We measure various diameters at various lengths, so to define how to approach. The management of a patient of aortic aneurysm, when you see, and if it is uncomplicated, unruptured, the first and foremost is control all the risk factors like smoking, stress, isometric exercise is avoided, BP control by beta blocker and RAS blocker to the lowest possible limits. Try to go to 110/70 if possible. Statin to be used in highest intensity, avoid pregnancy, but it's a shared decision. And then you have to intervene if patient is symptomatic, or patient gets ruptured and spontaneously sealed, or diameter is more than 5.5. If you look to this patient who had a diameter of 6.5, unfortunately, he never had symptoms, or if he had symptoms, he thought it was something else, but this patient should have been intervened much earlier. I won't go into the detail of surgical approach versus the endovascular repair approach, but for thoracic aneurysm, for most of the cases at the moment, endovascular repair is considered a better approach than surgical approach. It's a big teamwork. Cardiologist, interventionalist, surgeon, anesthetist, etc., large number of resources are used. It's an urgent procedure because patient had a ruptured aneurysm and it can re-rupture anytime. So we decided to put a graft stent. You can do it under brief intubation with anesthesia, or even it can be done under local anesthesia. You can do it either by exposure of femoral artery or by even percutaneous approach. But we have to be careful. It's not a simple procedure. There can be various complications like retrograde tear in the arch. Because you are covering a large amount of aorta and spinal arteries, it can lead to spinal cord injury and paraplegia, and there are other complications also. So let's go to the film so that you can understand how we did. So this is from the left upper limb. We went with a pigtail catheter. We did aortogram. You can see a small aneurysm here. You can see a large fusiform aneurysm here, which is a matter of concern. You can keep seeing it. By that time, we have to decide the landing zone and we have to oversize the graft. This is the aneurysm. So this is the graft stent for the sake of, so that you all can visualize and see how the graft stent looks like. It is pushed and we position the graft stent at the right place. And then we open the graft. The distal end of the graft, which is just above the celiac artery, opens once we remove the outer sheath. And then we release the proximal end. So this is a graft stent with a graft on which, so that it can seal the rupture and can make a new path. And this is the aortogram. After putting the stent graft, you can see the proximal end, which has fitted very well. And if you look at the entire aortogram with the area where aneurysm was, this was the area of aneurysm. So now aneurysm is sealed off and patient did well. Another case, which was a subacute type B aortic dissection. So this was another patient who ended up in some other hospital with severe chest pain, had severe issues, but then patient was taken as sort of coronary syndrome. Patient was managed medically. Luckily, patient survived for 4 or 5 days. On 4th or 5th day, patient was referred to our center. Patient had recurrent chest pain. Patient had uncontrolled blood pressure. So we did aortogram. I was very clear that patient is likely to have dissection. We did aortogram, and the entry point of the tear was just after the left subclavian artery, but there was enough landing zone for us. That patient's flap was going also right up to the celiac artery. So what we decided first in this patient, to put a stent, plain stent in celiac artery, so that it will keep the celiac artery mouth open so that nothing would go wrong. Patient didn't have any symptoms of abdomen. And then we thought that let's do celiac artery stenting, and then we put an endograft right from here to take care of most of the part of aneurysm. So dissection, as I talked to you, is type A, where it involves the ascending aorta, and type B doesn't involve the ascending aorta. It is there in this area. So our patient had exactly tear after the left subclavian artery, and you can see the film. So look at the film closely and look at here. And this is the false aneurysm. So this is the tear flap. You can see as a radiolucent shadow in between the dye. And this is the true lumen, this is the false lumen, and this is the entry point. So we located our stent device perfectly well, just 2 centimeters above. And then you look at the aortogram done after the placement of stent. There is no leak into the false aneurysm. On longer period of time, this stent graft will be placed. It will create a new, good false true lumen, and the false lumen will regress, and overall the ultimate effective true lumen diameter will increase over a period of time. Now, all these patients who undergo Such complex stent graft procedures should be monitored in ICU, local site, distal artery pulsations, BP and HR control, urine output, kidney function, and they need lifelong surveillance. So once you put an endograft, they need lifelong surveillance, and at times they need also aortogram with the dye. So in this person, there is only one concern for us was had only one working kidney with creatinine of 1.7. So doing repeated aortogram at 1 or 2 or 3 years interval is little challenge, but we'll make it out. So what is the carry home message as far as aortic aneurysm is concerned? Acute aortic syndrome, clinicians should have high index of suspicion. Any patient, when you suspect acute coronary syndrome, from back of your mind, you should always raise a question: am I dealing with aortic aneurysm and dissection? And if you can pick up even 1 out of 1,000, you can be lifesaver for that patient. Quick diagnosis through transthoracic echo, transesophageal echo, CT/MR is needed. BP control, pain relief is of prime importance. Refer the patient in time to the centers who are capable of doing aortic surgeries and endograft repair. Complicated patients need early treatment, and lifelong clinical follow-up is must. Thank you very much for your kind attention.